There's a specific feeling that comes with Medicare paperwork. It's not quite confusion. It's something closer to the sense that everyone else received instructions you somehow didn't get, like there was a class, and you missed it, and nobody told you it was mandatory. You open the letter, you see Part A, Part B, Part C, Part D, and somewhere in the back of your mind, a quiet voice says, "I'm 65 years old. I should know what this means." That voice is wrong about one thing. Not knowing this isn't a gap in your intelligence. It's a gap in what the system ever required anyone to explain to you. That's what today's video is. The explanation you were never given, delivered the way it should have been from the beginning. By the end of this, you'll know what each part actually covers, why the system is built the way it is, and, most importantly, where the decisions that actually affect your life are hiding inside it. Not a pamphlet, not a checklist of acronyms, the actual map. Let's take this apart together. Here's the first thing nobody explains. And it's the thing that makes everything else make sense. Medicare doesn't have 4 parts because someone sat down and designed a 4-part system. It has 4 parts because it was built across 4 different decades, by 4 different legislative efforts, each one trying to solve a different problem that the previous version had left unsolved. Part A and Part B were created in 1965. Lyndon Johnson signed Medicare into law as part of the Great Society legislation, and at that point, the goal was relatively narrow: cover hospital stays and doctor visits for Americans over 65. That's it, hospital and doctor. That was the whole system. For almost 40 years, that's what Medicare was. No prescription drug coverage, no vision, no dental, no hearing. If your doctor prescribed you a medication and you went home and took it every day for the rest of your life, Medicare didn't pay for a single pill. Part D, the prescription drug benefit, wasn't added until 2003. 38 years after the original law. Under the Medicare Modernization Act, signed by George W. Bush, which means that if you spent any part of your adult life thinking Medicare covers healthcare, you were right about the spirit and wrong about the details. Because for nearly 4 decades, it didn't cover the one thing most older Americans use most. Part C, Medicare Advantage, isn't technically a new set of benefits. It's an alternative delivery mechanism. Instead of receiving your Medicare benefits directly from the federal government, you receive them through a private insurance company that has contracted with Medicare to provide at least the same coverage. More on that distinction in a moment, because it matters more than most people realize. The point right now is this: when you look at the 4 parts of Medicare and feel like they don't add up to a coherent whole, you're right, they don't. Because they were never designed as a whole. They were designed as a series of patches, each one responding to a gap the last patch left behind. That's not your confusion. That's the architecture. So let's go through them, not as definitions, but as real coverage. What each part actually pays for, what it costs you, and what it leaves exposed. Part A is your hospital insurance. It covers inpatient hospital stays, skilled nursing facility care after a hospital stay, hospice care, and some home health services. For most people, Part A has no monthly premium because you paid into it through payroll taxes during your working years. If you worked and paid Medicare taxes for at least 10 years, you've already paid for Part A. What Part A does not cover? The doctor who visits you while you're in the hospital. That's Part B. Part B is your medical insurance. It covers doctor visits, both inpatient and outpatient, outpatient procedures, preventative care, durable medical equipment, and most medically necessary services that aren't a hospital stay. Part B has a monthly premium. In 2025, the standard premium is $185 per month. Higher income enrollees pay more. That's a separate mechanic called IRMAA that we'll cover in another video. Here's the thing about original Medicare, Parts A and B together, that almost no one tells you before you need to know it. There is no out-of-pocket maximum. Most insurance, including employer insurance most people had for decades, caps how much you can spend in a given year. Once you hit that cap, the insurance covers 100%. Original Medicare does not work that way. There is no ceiling. A catastrophic illness, a long hospital stay, a serious surgery, a prolonged recovery can cost you amounts that most people are not prepared for if they're relying on Parts A and B alone. That gap is why Medigap supplement plans exist. That gap is also part of why Medicare Advantage was created. We'll come back to both. Part D is your prescription drug coverage. It's a standalone plan, separate from Parts A and B, that you enroll in through a private insurance company approved by Medicare. Each Part D plan has its own formulary, the specific list of drugs it covers, and at what cost tier. One of the most important changes in recent years, starting in 2025, there is a new $2,000 out-of-pocket cap on Part D drug costs. For people on expensive medications, that change is significant. For years, there was no cap, and the cost exposure was real. Part C. Medicare Advantage is the option that replaces Parts A and B with coverage delivered through a private insurer. Most Advantage plans also include Part D drug coverage, and many include extras like dental, vision, and hearing that original Medicare doesn't cover. The trade-off. You're now working within a network. Prior authorizations, referrals, plan-specific rules. That trade-off is worth it for some people and genuinely not worth it for others. And the answer depends on factors specific to your situation, not on which plan had the best ad this fall. Now here's where the video shifts. Because knowing what each part covers is useful. But knowing where the gaps between parts are, that's what actually protects you. When you become eligible for Medicare, you face a fork that most people don't realize is permanent. You either stay in original Medicare Parts A and B and add a standalone Part D plan for drugs, and potentially a Medigap supplement to cover the costs original Medicare leaves behind. Or you enroll in Medicare Advantage Part C, which bundles A, B, and usually D into a single private plan with its own network, rules, and cost structure. This is not a small decision, and it's not one that works out the same way for everyone. The reason most people feel overwhelmed at this fork isn't because they lack the intelligence to evaluate it. It's because the advertising ecosystem around both options is not designed to help you choose the right one. It's designed to enroll you in one. The Medicare Advantage television ads you've seen, the ones with the celebrity spokespeople, the ones that lead with free dental and free gym memberships, they are not public service announcements. They are sales materials, and the part the ad doesn't mention is always the part that matters most. The network restrictions, the prior authorization requirements, the fact that your current doctors may not be in the plan. Original Medicare, on the other hand, has no network. If a provider accepts Medicare, and most do, you are covered, anywhere in the country. For people who travel, who have health conditions that require specialist care, or who simply want the freedom to choose their own doctors without asking permission first, that is not a trivial advantage. But original Medicare's lack of an out-of-pocket maximum means that without a supplement, a serious illness can create financial exposure that a fixed retirement income cannot absorb. This is the architecture of the decision. Not which plan has better benefits, but which gap concerns you more, the network restrictions and prior authorizations of Advantage, or the uncapped cost exposure of original Medicare without a supplement. That question has a different answer depending on your health, your doctors, your location, your income, and your risk tolerance. And here's what I want you to hear clearly. The fact that this decision is complicated is not a reflection of your ability to make it. It's a reflection of a system that was built in pieces, patched over decades, and handed to you with a deadline and no manual. The confusion was designed into the system. Understanding it, the way you now understand it, is not something you were supposed to arrive at on your own. That's not a gap in your knowledge. That's a gap in what the system ever required anyone to explain to you. If you want to take what's here further before your enrollment window, there's a resource in the description built exactly for this moment. It's a 7-page Medicare Clarity Checklist. The specific questions to ask before choosing any plan, a plain language glossary of the terms you'll encounter, and a guide to the enrollment windows so you know exactly when each decision has to be made. It's the tool that turns orientation into a decision you can make with confidence. The link is in the description and in the pinned comment. So let's close with the 3 things that matter most before you make any Medicare decision. Not everything. There's more to cover in future videos. But the 3 that, if you understand them, will protect you from the most common and costly mistakes. First, the enrollment windows are not flexible. Your initial enrollment period, the window when you first become eligible, opens 3 months before your 65th birthday and closes 3 months after it. That's a 7-month window. If you miss it without a qualifying reason, you will pay a permanent penalty on your Part B premium, 10% for every 12-month period you were eligible but didn't enroll. Not a one-time fine, a permanent monthly increase for the rest of your life. There is one major exception. If you're still working and covered by employer insurance through a company with 20 or more employees, you have a special enrollment period when that coverage ends. This is the situation where most people make the most expensive mistakes assuming their employer coverage works the same way COBRA does. It doesn't. Second, the supplement decision is much harder to make later than it is to make now. When you first enroll in Medicare, you have guaranteed issue rights for Medigap supplement plans. That means insurers cannot deny you coverage or charge you more based on your health. If you enroll in Medicare Advantage first and later want to switch to a supplement, in most states, insurers can medically underwrite you. They can deny you based on pre-existing conditions. They can charge you more. The window where you could choose freely has closed. This is the part most people don't know until it's already too late to use it. And it's why understanding the fork at the beginning matters more than most Medicare explainers are willing to say. Third, and this is the one that will serve you most in every conversation you have from here. Every Medicare plan has a summary of benefits. Before you enroll in anything, Advantage, Supplement, Part D, ask for the summary of benefits in writing. Not the brochure, not the sales call. The summary of benefits. It will tell you, in specific terms, what is covered, what is not, what your cost sharing is for the things you actually use, and what the network looks like. If someone is reluctant to give it to you before you sign, that reluctance is information. Before you sign anything, get it in writing. If you want the complete question guide for evaluating any Medicare plan, including the exact questions the summary of benefits should answer, the Medicare Clarity Checklist is linked in the description and in the pinned comment. It was built for exactly this moment. When you first started looking into Medicare, what was the one thing you wished someone had explained to you before you needed to know it? So here's where we've landed. Medicare has 4 parts not because someone designed a 4-part system, but because the system was built across 4 decades by 4 separate legislative efforts, each one responding to the gaps the last one left behind. Part A covers the hospital, Part B covers the doctor, Part D covers the prescription. Part C, Medicare Advantage, is an alternative way to receive all of it through a private insurer with different trade-offs. The gaps between those parts are where the real decisions live. The supplement versus Advantage fork, the enrollment window, and its permanent penalties. The guaranteed issue rights that exist now and may not exist later. You now know where those gaps are. You now know why the confusion existed. Not because you failed to study something you should have known, but because the system was never required to explain itself to you as a whole. There are more decisions ahead in this chapter. Social Security timing, income planning, how to evaluate an advisor. Each one has the same architecture as this one. Complexity that looks intimidating from the outside and navigable once you see where it actually lives. That's what every video on this channel is. One more piece of the map. One less thing you're carrying without understanding. Today was the foundation. Everything else builds from here. I'll see you in the next one.